This is the second recording for the patient care and radiography with an introduction into medical imaging. This is Chapter 9. This is pages 146 through page 168. When possible, this most likely will be broken up into two separate parts. Infectious diseases, emerging diseases. There are many new diseases in the world, and some old diseases once thought to be under control are returning in epidemic substantially increased proportions after years of low-level incidence. As workers in the healthcare field, you will be on the front lines of the exposure to both old and new diseases. The infection control department within a hospital is responsible for keeping track of all of these infections and developing infection control policies to protect you, other staff, and patients based on recommendations from the Center of Disease Control and Prevention, CDC. The CDC monitors and supplies the types of infections occurring. The CDC monitors and studies the types of infections occurring in the nation, compiles statistical data about these infections, and publishes this information in both a weekly report and an annual surveillance summary report. The World Health Organization, or WHO, studies, collects, and compiles infection data from every country in the world and makes this information available worldwide. Emerging diseases include new diseases appearing in the population, existing ones that are rapidly increasing in an incidence or geographical range, through resurgent or recurrent old diseases caused by an old or mutated pathogen. These emergencies is participated by many factors: increased human exposure to vectors in nature, population growth and immigration to crowded cities, rapid international travel and transportation of goods, contact with new strains of dangerous pathogens mutated caused by overutilization of antimicrobial agents, breakdown of public health measures, climate change, bioterrorism. Inadequate public health measures in South America and Africa have resulted in cholera. In Africa have resulted in cholera outbreaks due to poor sanitation and insufficient chlorine levels in water supplies. Drastic political changes and the resulting deterioration of public health programs accounted for the resurgence of diphtheria. In the former Soviet Union, Russian immigrants introduced the disease to the United States. The outbreak of hantavirus pulmonary syndrome, a potentially fatal respiratory disease, in southwestern United States in 1993 was blamed on a six-year drought brought by mild, wet winters and spring. These conditions were favorable for a dramatic rise in the population of deer mice, which increased the contact with humans. Hantavirus infection is contracted by inhaling dust containing particles of droppings of these mice. The unusually warm temperatures in Mexico and southwestern Texas in 1995 provided ideal conditions for mosquitoes carrying dengue fever and to reproduce and transmit the flavivirus. Dengue fever is also called breakbone fever, is characterized by high fever, headache, muscle and joint aches, malaise, and often a rash. The disease may range from a mild illness to a severe, sometimes fatal condition with hemorrhage and shock. Reforestation increases the population of deer and deer ticks, the vector of Lyme disease. When humans moved closer to these forests, it is easier for the pathogen that caused Lyme disease to spread from its normal host into humans. Human migration from isolated areas of the world to crowded cities is responsible for the spread of once localized infections, such as human immunodeficiency virus, HIV, cholera, and dengue fever. International travel has a potential spread of many pathogens around the world. The outbreak of anthrax in the United States in 2001 demonstrated the ease with which terrorists can spread disease once thought to be under control. This has raised public concern about other diseases that could affect a large portion of the population. Travelers from Asia brought the virus for severe acute respiratory syndrome, SARS, to North America in the spring of 2003. Air transport used tires from Asia introduced the mosquitoes carrying dengue fever to the United States. Influenza spreads rapidly across the globe as travelers meet and exchange infections. Influenza viruses mutate readily, resulting in many different strains of influenza that frequently appear in new strains. In recent years, deadly strains of the H1N1 swine flu and H5N1 virus bird flu have been on the news. Although bird flu has not moved significantly into the human population it was originally feared, swine flu has reached widespread pandemic proportions in humans in 2009. Fortunately, a vaccine for this virus was quickly developed and made available, and the virus has now mutated to a less virulent form. Although sometimes, you're going to have to excuse me my pronunciation of some of these names, Escherichia coli bacteria exist normal flora in the digestive tract. Some strains of this organism can cause serious illness. Ingestion of food contaminated with E. coli 0157 H7, so 0157 H7, causes diarrhea and hemorrhagic uremitic syndrome. This strain of E. coli, which can cause severe illness and death, has been linked to the consumption of undercooked hamburger meat, unpasteurized apple juice, dried venison, contaminated spinach, and other foods. Other deadly strains of E. coli identified as 104H4 caused the deaths of dozens of people in Germany and many serious illnesses in France in May of 2011. June 2011 caused the first death due to H04 or 104H4 was reported in the United States. At first, the outbreak was traced by scientists to bean sprouts grown on a German farm, which the bacterium was then identified in other types of eligible sprouts as well, and is believed to have originated in the fungu Greek seed grown in Egypt and mixed with other seeds when packaged by a firm in the United Kingdom. This demonstrates how rapidly emerging diseases can spread and how difficult it may be to identify the source. This particular bacterium has two traits that may be responsible for causing the deadliest E. coli outbreak in recent history. One trait is the production of a toxin called Shiga toxin, which causes severe illness, including bloody diarrhea and kidney failure. The second trait is that the bacteria aggregate on the surface of the intestine and form a dense pattern that enhances the ability of bacteria to pump toxin into your body. Unlike other strains, this one tends to attack young and middle-aged women. The most recent multi-country outbreak is that of the Ebola virus, which has reached historic proportions in 2014 in West Africa, originally identified in 1976 near the Ebola River, where there are 5 strains of Ebola virus, 4 of which affect humans. Ebola spreads quickly through direct contact with blood and bodily fluids from an infected person, object contaminated with the virus, and infected fruits, bats, and primates. Typical flu-like signs and symptoms of this infection appear 2 to 21 days after exposure and include fatigue, headache, weakness, diarrhea, abdominal pain, vomiting, fever, and hemorrhage. The statistics provided by the CDC over a 1-year period in 2014 indicate that there were more than 21,400 cases and approximately 8,500 deaths across 9 countries, and roughly 99.8% of those occurring in Sierra Leone, Guyana, and Liberia. The rapid transmission and delay at onset of symptoms have induced many countries, including the United States, to set forth strict nationwide Ebola healthcare preparedness and isolation procedures. There is no vaccine approved by the United States Food and Drug Administration used against Ebola, although experimental vaccines are under development. Basic interventions used to treat symptoms and complications increase the chance of survival. Proper use of personal protective equipment, PPE, and disinfectant protocols are the most effective ways to prevent and contracting this virus. Healthcare-associated infections. Hospital-acquired infections, also called as nosocomial infections, are defined as those that occur with more than 48 hours after being admitted to a hospital. A more recent term for these conditions is healthcare-associated infection, or HAIs. Approximately 7,222 722,000 patients admitted to hospitals each year acquire HAIs, and although many of these infections are not life-threatening, the CDC estimates that 75,000 patients die each year of hospital-acquired infections. HAIs are one of the 10 leading causes of death in the U.S., accountable for 28 to 34 billion in healthcare costs, and notably, most of them are preventable. Medical settings provide an ideal environment for the development and transmission of HAIs. Typical sources of infection include contaminated hands of healthcare providers, contaminated instruments, urinary catheters, ventilators, central lines, and surgical sites, which can allow microbes to gain easy entrance into the body. Invasive procedures permit pathogens to enter the bloodstream and overcome the defense mechanism of immunocompromised patients. The wide and inappropriate use of broad-spectrum antibiotics has led to the development of drug-resistant infections in hospitals as well as the community. Some of these infections are untreatable because they are resistant to the available drugs. Development of new drugs take time, is costly, and does not seem to have a lasting solution for the complex problem. There are several HAIs that greatly concern healthcare providers and their hospitalized patients because they are multi-drug resistant. This means that the infectious agents are resistant to more than one antibiotic. Methicillin-resistant Staphylococcus aureus, MRSA, and, again, excuse me if I botched this, vancomycin-resistant Enter coli, or VRE, both contribute to surgical wounds, urinary tract, and bloodstream infections. MRSA can also cause respiratory infections. Penicillin-resistant Streptococcus and Pseudomonas aeugurus cause respiratory infections. The overuse of antimicrobial agents and poor infection control practices have been implicated in the emergence and spread of these multi-drug resistant infections. These pathogens are very difficult to treat. Intensive infection control is required to limit their spread. MRSA has been recognized as a problem in the healthcare setting for the last 20 years. Most recently, MRSA has become a problem in the community and referred to as a community-associated or CA-MRSA. According to the CDC, this variant has been associated with the recent antibiotic use, sharing contaminated personal items, living in crowded settings, and poor hygiene. This form of MRSA is associated with skin and soft tissue infections that are treatable with alternate antibiotics. The following groups have been affected: injected drug users, men who have sex with men, prisoner inmates, military recruits, children in health and child care facilities, and athletes. Even today, other organisms are adapting to the drugs used to treat them and will soon emerge to present new infection control threats in healthcare facilities and possibility in our communities. Another type of HAI is very common in the hospital environment is Clostridium difficile colitis, a gastrointestinal infection that causes diarrhea. C. difficile, or C. diff for short, is a gram-positive bacillus that is especially difficult to control because it is a spore-forming bacterium that is not eliminated by routine asepsis methods. Patients receiving antibiotic therapy are particularly susceptible to developing this infection because antibiotics tend to upset the normal balance of intestinal flora. About 20% of hospital patients receiving antibiotics develop C. difficile infections. Treatment is usually quite successful, but about 20% of treated patients relapse, sometimes developing a chronically recurring disease. Bloodborne pathogens, HIV and AIDS. You have no doubt familiar with the abbreviations HIV and AIDS. HIV, which stands for human immunodeficiency virus, is also named because of infection with the virus results in the destruction of the individual's immune system. In the early 1980s, HIV was identified as the cause of acquired immunodeficiency virus syndrome. AIDS is called stage 3 HIV infection for reporting purposes. Two major types of HIV have been found to infect humans: HIV type 1, HIV-1, the predominant type throughout the world, and HIV type 2, HIV-2, found primarily in the heterosexual population in Western Africa. HIV is an NRA retrovirus. RNA viruses are called retroviruses because they replicate a backwards manner, converting the RNA to DNA after they invade the host cell. HIV can infect a number of different cells in the body, including cells of the central nervous system, but it is the adverse effect of immune system cells that produce the immunosuppression and manifestation of AIDS. This virus has specificity for the receptor of the CD4 lymphocytes, attaching to and invading these cells and becoming a permanent part of their genetic material. Cell replication produces infected CD4 cells and additional HIV. An HIV-infected individual can transmit the virus to others a few days after infection. Without therapy, this individual will pass through several phases of infection over a span of months to years before exhibiting the immunosuppression of full-blown AIDS. In the early stages of the infection, there is usually a brief period of flu-like symptoms, often followed by years without symptoms. During the asymptomatic phase, the virus is silently replicating in the body and decreasing the number of CD4 lymphocytes. At the end of the asymptomatic period, before the full development of AIDS, the individual will experience night sweats, oral infections, weight loss, persistently enlarged lymph nodes, and low-grade fever. The appearance of AIDS is characterized by a low CD4 count and the occurrence of multiple opportunistic infections of malignant diseases. The most common opportunistic infection observed is pneumocytosis carni, pneumonia. Others include, again, excuse me if I botch these, Eucantinotis, Candida, disseminated herpes, and cytomelignovirus. There is also increased risk of contracting tuberculosis and developing active disease. Kaposi sarcoma and a malignancy of the pigmented skin cells is the most common form of cancer affecting AIDS patients. Although no cure exists, antiretroviral drugs that first became available in 1996 have significantly prolonged the time required for the AIDS infection to progress to AIDS. With early diagnosis and appropriate treatment, it appears that progression to AIDS may be delayed indefinitely for some individuals. The last hemodynamic research has hinted at the groundbreaking possibility of successfully treated by utilizing stem cell transplant to functionally cure HIV-positive patients. Fortunately, the AIDS virus is not acquired by casual contact. Touching or shaking hands, eating food prepared for by an infected person, and contact with drinking fountains, telephones, toilets, and other surfaces does not result in transmission of HIV. The routes of transmission are through sexual contact, contaminated blood or needles, fluids containing blood, or from mother to fetal via placenta. Infection can also be transmitted to infants through breast milk. According to the CDC, more than 1.2 million people in the United States are living with HIV infection, and approximately 14% of the infections are undiagnosed. The global annual mortality rate is 1.5 million, and the worldwide cumulative death toll is over 39 million people since the pandemic began. The incidence of AIDS has dropped significantly since the mid-1990s due largely to prevention efforts. The survival rate has increased as a result of medical treatment and early diagnosis. In spite of these factors, the total number of HIV patients continues to rise. This is attributable to not only new cases but also to the increasing number of HIV-infected individuals who have used retroviral drugs and thus avoided converting to AIDS. Despite the improving statistics, the spread of HIV and AIDS is very troubling. Public health concern is particularly focused on the number of new HIV infections occurring nationwide. Males who have sex with males account for the largest number of cases for AIDS in this country, followed by intravenous drug users and individuals engaged in high-risk heterosexual contact, unprotected contact with a person known to have or be at a high risk for having HIV. The incidence of AIDS is increasing at a faster rate than the incidence of HIV within the following groups: non-Hispanic blacks, Hispanics, and women. The higher the rate of AIDS in these people has been attributed to poor access to health care, which has improved in the last few years, or failure to follow the prescribed drug regimen. The continued decline in AIDS diagnosis and death will depend upon better access to health care, simpler drug regimen, and continued development of effective antiretroviral drugs and other therapies. As a healthcare worker in today's world, you must expect to encounter unidentified and undiagnosed cases of AIDS and other bloodborne diseases. These patients' right to confidentiality regarding AIDS diagnosis within the hospital setting prevents healthcare workers from being informed about diagnosed cases, and additional undiagnosed cases may be encountered as well. For this reason, anxiety about HIV infections is typically understandable among healthcare workers, but the occupational risk is not great. The vast majority of healthcare workers infected with HIV were exposed as a result of activities unrelated to their work. The most common occupational exposure is the needle stick, but according to the CDC, the probability of infection following is only 3 out of 1,000 exposure, or 0.3%. The risk of infection from exposure to mucous membranes is 0.009%, or less than the common types of exposure carry even less risk. Thousands of needle sticks have been reported over the years, but as of December 2001, the most recent report of this type available, only 57 healthcare workers with no other identified risk factors have been diagnosed with HIV positive. The other 57 cases of the 57 cases, 26 developed AIDS. If current statistics were available, the number of diagnosed cases in healthcare workers would, of course, be greater than the ratio of needle sticks to infections would be similar. The implications here is obvious. Although prevention at work is essential, self-care in terms of safe sexual practice and avoidance of other higher risk activities is equally crucial.